Welcome everybody. This is the Department of Internal Medicine Grand Rounds. Today is March 14th, 2024. Just a reminder to everybody online, we have a hybrid format. We're in person on the second floor in Sanger Hall, room 2020. Today's talk is sponsored by the Division of Hematology on Oncology and Palliative Care. Our talk today is the evolving care of prostate cancer, presented by Dr. Asit Paul. To introduce Dr. Paul, I'm going to invite our chair for the division, Dr. Renato Martins, to introduce our speaker. Dr. Martins?
Well, your pronunciation of my first name was perfect. Not that I care, but
I mean, the chair's been doing it right.
Every time. So anyway, it's an honor for me to present Dr. Paul. We met when I came here, and he has been the reference for prostate cancer care and research in this area of the country. Has been very active in research. He's the chair of our Data and Safety Monitoring Board, which is an important component of our Cancer Center grant. And he's teach me and you as well about the evolving care of prostate cancer. He gave the same talk 8 years ago, and I suspect that he's going to have 0 slides that overlap, because it's really quite amazing how things have been changing in oncology, and they will continue to change. So.
Thank you, Dr. Martin, for the generous introduction, and Dr. Sahim to be here for the grand round. And this is the predominantly virtual audience. So thank you so much who makes time to attend the lecture. Wait, the arrow. Oh, this one. Okay. All right, so as you know, we like to talk about prostate cancer, and I'm going to the talk in a minute. So it's some of a disclosure. I don't have any active conflict of interest. I have some consultants in the past, which I mentioned here. The first question is why we are talking about prostate cancer. I think it's very important. I know we practice oncology. We need to know because we need to treat, but why in a grand round? Predominantly, I think, non-oncology audience. I think it's very important, and there's some reason. One is this is the most frequently diagnosed new cancer in American man. Is about 1/3 of all new cancer diagnoses is prostate cancer. It's a huge, substantial burden of a cancer in the United States. And importantly, actually, majority are diagnosed in a very early stage. Almost 80%. So they are cured. So they are cured, and they see us a few years as a follow-up, and then they go back to community. And then they develop lots of issues related to their cancer diagnosis, related to their treatment. And I'm going to talk a little bit detail about it. There is a significant delayed and ongoing effect related to the prostate cancer therapy. So they can meet, I'm sure that you as a physician in your practice, in the hospital, you'll meet prostate cancer patient or somebody who survived prostate cancer in the clinic, and they will ask you questions. And I think it is a good idea to do some update. Many of you probably know many of the things I'm telling today, but it's trying recapping stuff. And number one thing, we have some concept that patient die with prostate cancer, not because of it. So I see it all the time. Patient tell me, doc, I'm not going to die from it, right? I'll be cured and nobody dies from it. So that's partially true. And one thing is, if you look at that, just because of the number of patients we diagnose, this is the second leading cause of cancer-related death in the United States, just after lung cancer. So this is a huge number of patients who die. So this is really not true that patient die with prostate cancer, not because of it. And this is primarily true who has metastatic disease. So majority patient get cured after initial treatment, maybe surgery, radiation, but about 30% patient develop metastatic disease, and they most likely will die from it despite of treatment. So death burden is substantial for those patients. So at the same breath, so what I talked, that substantial number of patients are actually cured. So they require survivorship care. What kind of care we need? They may develop new cancer in their lifetime. They may develop cancer related to their treatment. They may have like recurrence of the cancer which was diagnosed many years ago. So I think as a practitioner, they may go to a primary care, family care, endocrinologist, substantial number of patients with cardiovascular problems. So they develop metabolic syndrome, high blood pressure. So they may meet you in the cardiologist office. So these are the reason I think it is important that we talk about prostate cancer a little bit more in a general term, not as a specialist term. So my lecture mostly would be actually in a general discussion on prostate cancer rather than too much of a molecular level discussion, what we oncology generally do nowadays for any cancer. So this is the grand round I did 2016. And this is the format I did last time, but I'll keep that format exactly as it is. But Dr. Martins told us almost every slide has changed because there's so much changes over the last 8 to 10 years. So we'll primarily focus on that. And then I'll spend a few minutes on the survivorship care, which I feel like extremely, extremely important. So what is the burden in this country and globally? So if you go a little bit of ancient time, cancer was not that common. You can actually find a reference in Egyptian papyri. It's as early as 300 years before Christ. There are a number of these papyri, they mention that even don't try to treat the cancer because you cannot cure it. So there are, but there are not that many actually prevalence, at least by the documentation, maybe a documentation issue, diagnostic issue. But at this time, this is the second most common cause of death after heart disease. And if you keep track of the statistics, it's actually very close. It's trying to, catch heart disease as the #1 killer in this country. But why that was not that common previously, why it is common this time? So I put a quote from one of my most favorite book, and that shows that civilization did not cause cancer, but by extending human lifespan, civilization unveiled it. So that is so true because we used to live short period of time, and cancer is a disease of elderly. It happens more when you're old. So they used to live short, so you don't have a chance to get genetic mutation and others to get cancer. Other things is actually there is this data behind it that before industrial revolution, we did not have that much of exposure to carcinogen. We have pollutants are not that common. And now actually the modern lifestyle, diet, exercise, activity, everything makes us very vulnerable to cancer. And definitely the advances in diagnosis and the medical science and everything makes more common to diagnose cases, but it was not that common in the past. Interestingly, some of the earliest evidence actually we found in the Egyptian mummy. And there is a project in Lisbon, this Lisbon Mummy Project. They actually found a mummy which is like 285 before Christ. And because of the modern technology, they could able to digital computer tomography, and they found classic bony sclerotic lesion in the bone. And because this is a mummified lesion, they cannot do too much of a biochemical studies, but there are other mummies they actually could able to do it. They found that there's a PSA-rich lesions in the bone. So I'm not going to detail into that, but the bottom line is many of the very earliest evidence actually came from prostate cancer. So it's, even though it's described not that common, I think it was common at that time as well, for whatever reason. And then in the modern medicine, we heard about prostate cancer for the first time as a case report in 1853 at Lancet. This is Dr. Adams, a surgeon from London Hospital. He found it, and this is the first time we started doing histopathological studies. It's a biopsy-proven diagnosis. But one comment I like to, he told a disease of very rare recurrence. So he thought this is very uncommon. But at the end of 19th century, people started having lots of prostatectomy because of urinary retention. The urologist used to do a lot of prostatectomy and they got biopsy. And they found, oh no, it's not really that uncommon. And then this is the, actually I talked about the statistics in the United States. It's a global problem. There are about 10 million new cases, about 5 million died every year. And it's like about 1 in 6 patients with new diagnosis in prostate cancer in the world. Interesting, this is a good observation. If you look at this curve, that where the geographical location of prostate cancer. So this is Oceania, Northern America, Europe. So these are the industrialized nations who has more prostate cancer than other nations. It's actually true, not only for prostate, it is also for like lung cancer and other like colon cancer, this is true. So this is really a matter of research, why that is happening more in the industrialized country. The question is it a disease of affluence or is it just a reflection of better healthcare and access? So patient has more access, they get diagnosed, but is it related to something which is in the industrialized nations' health infrastructure or the living lifestyle? If you look at this, so these are the lung, prostate, and colon. So they who have high, we call human development index, which is a measure of actually the health status, education, and income. So you have a higher health, high HDI, you have a more cancer than low. And in the prostate cancer patient, it actually correlation is stronger. There are some other observation that even though despite of very common culture and maybe some of the genetics, the China has a low incidence of prostate cancer, but Hong Kong does not have. Hong Kong has a very high rate of prostate cancer. So we know the socioeconomic condition, Hong Kong is better than in general from China. And also, this is another one, this is dramatic because one of the lowest rate of prostate cancer is in actually India in the world. But the people who migrated from India to United States, they have a very high incidence. So I can give you the number, about 4% among the all cancer in India. But in the United States, the Indian living in US, they have 30%. It's like 6 to 8 times. So that's the question comes up. Is it really a reflection of healthcare access or something else? Is it genetics? Is it affluence issue? Is it lifestyle? So we have to wait for get more definitive answer. But the bottom line is it's kind of more common in countries who have a like a higher HDI or a high human development index. In the Virginia, it's actually exactly mirrored the national trend. So you have the most frequent new cancer diagnosis. And then after the lung cancer, it's the second most common cause of death in the male population. And this is the definitely, we'll talk a little bit more about it, that it's more common in African American population. And then there is a geographic mapping of the prostate cancer incidence. And interestingly, if you look at the southeast part, I think it's probably Hampton and Virginia Beach and this area in the Elizabeth River Basin. Forgive me if I'm not sure about the geography, but so there are some assumption that those are the area has much more contamination from naval movement and the military facilities there. So there are some data coming out that maybe prostate cancer is more related to carcinogen and that kind of stuff in that area. But it's definitely, if you look at the map here, incidence is significantly higher in the southeast area of the Virginia. So we kind of a little bit of talk about it. The established risk factor is age. The older age people, any cancer, if you are older, you have a higher risk of cancer. It's much more common in prostate cancer. And African American population has the significant risk factor about their biology. They are diagnosed younger, they have more aggressive disease. And the family history, about 10 to 20% patients are inherited. So it comes from the family, but rest of them. There are some inconsistent evidence that diet, obesity, low androgen level, carcinogens, and lifestyle factors, these are related to prostate cancer diagnosis. We see from veteran population that are exposed to Agent Orange, they have a higher risk of prostate cancer, but direct causal relationship is not really there. But there are some data and there are some definitive data, but really these are the three factors which definitely put at a higher risk of prostate cancer. And then we talked about 60% of patient is more than 65 years old. So it's a disease of elderly in general. Median age in this country is 67 years. So it's a higher, as we age more, we have a more risk of prostate cancer. It's very true and everybody knows. One concerning factor is, like many other cancer, actually prostate cancer, even though we think that the disease of elderly is getting more and more diagnosed in the younger population. The question is again, are we looking at the diagnostic side more on those patients? And there are some data, very preliminary, small population, that if you diagnose younger, you have a higher risk of death than if you're diagnosed in the old days. So if see, even in the curable stage 1 and 2 is very curable stage. It's almost 100% survival at 5 years. But if you are diagnosed below 40, this curve actually dipped down. And definitely for metastatic disease, their mortalities. So we don't know that why that's happening. I think it's much more data coming in, particularly colon cancer in younger population and other disease. But prostate cancer is not too much focused on a younger population, but there are data suggesting that we might have to look into this. And then the race factor, as I mentioned, that African American population is almost 60% higher risk of getting prostate cancer than any other ethnic population. Then the death is, if you consider African American, which is here in 1,000 patients, and then death is almost double there compared to their white counterpart, or even with all the races. So we know that there are lots of studies done. The biology is aggressive. They're diagnosed little later than it should be. And then one of the very important factors is that the disparity in healthcare, as we know that Massey Cancer Center is a big project looking into that. So I think prostate cancer is one population which is significant disparity in healthcare, which might affect the mortality in this population. All right, so as I told, the about actually 10 to 15% patients are inherited. And one of the most common is the BRCA2, and the BRCA1, BRCA2 is also common genetic alteration in the breast cancer population, and they're actually part of the Lynch syndrome. If you have like the familial syndrome-wise, but BRCA2 is the most common. About 40% of the patient has BRCA2 alteration, and there is a, depending on what is the mutation profile, the risk, and BRCA2, which is the most common, about 3 times more higher. And there are other mutation we call prostate cancer panel. We do when we test in the clinic, they have a different level of risk factor, but overwhelmingly almost 40% or more are BRCA2 mutation. So that is a common question we hear from the patient, actually. I don't know how much you have this question about, because most of the patient with, as we age, we develop prostatic hypertrophy. And they go to urologist, and some of them diagnose prostate cancer. Is there a direct relationship with the benign prostatic hypertrophy and prostate cancer? There are some common risk factor. Older age, is both happen in the setting of chronic inflammation. They are both androgen dependent. They're actually, when you did the genomic profile, there's some shared genomic changes. And the age profile is very, very similar in the disease of elderly, but there is actually no causal relationship between benign prostatic hypertrophy and prostate. This completely different disease in terms of pathogenesis and biology. All right, so we'll talk briefly about biology of the disease. So if you look at the prostate cancer, it is it's actually defined as 3 zones. These are the peripheral zone and the central zone and the transitional zone here. When you talk about prostatic hypertrophy, it happened in the periurethric zone, which push the urethra and patient with symptom. Prostate cancer predominantly happen in peripheral zone. And this is because they are so much prone to inflammation and atrophy. Central zone is very resistant to changes, so they rarely get any cancerous changes in there. So when you talk about prostate cancer, actually, this is a big part of the prostate, almost 2/3 of the prostate is peripheral zone. So that's why there is a good place to develop cancer in the prostate. It's not a tiny, small space. Okay, so, but most commonly happen in the peripheral zone of the prostate. If you cut a prostate after surgery, that looks like this, and these are the two peripheral and is the urethra here. And then this is a sequential process. So that doesn't happen in a day. It happens in a very relatively slow process. So it is a prostate intra tumor neoplasia, low grade, high grade, and carcinoma in situ, adenocarcinoma, then that develop metastasis. This is the normal prostatic cell. The prostate, the epithelium of the prostate, there's a luminal cell, there's a basal cell, the neuroendocrine cell, and these are the stroma. Prostate hypertrophy happen predominantly in the stroma, and there are small component of neuroendocrine disease, neuroendocrine cancer for prostate, but predominant disease of the epithelium, the prostate cancer. But they have a distinct genetic alteration in every step, and actually you can have some prognostic implication knowing what is the genetic profile at this certain time point. And that this is a very important slide, and so is really is hormone dependent, and the hormone is the androgen or testosterone. So testosterone comes 95% from the testis and 5% from the adrenal gland, and it is regulated, as you know from the physiology, then centrally. So hypothalamus, pituitary axis release the luteinizing hormone, and luteinizing hormone coming from pituitary has a luteinizing hormone releasing hormone, which either stimulate testes or adrenal gland to release the androgen. And for the survival of prostate itself, the normal prostate gland, and as well as cancer, androgen is very, very important. So if you block the androgen, then most likely the prostate epithelium starts dying, because this is a lifeline for them. And that was actually shown many years ago. 1966, we got 2 Nobel Prize on the concept that if you castrate or took the testosterone out, this is the effect of surgical castration. This is the effect of centrally acting luteinizing hormone axis. Both of them had shown that if you cut both of them, block them surgically or medically, then the prostate gets shrink. So this is the basic fundamental concept, which still has the significant implication how you treat prostate cancer patients. So there is a Nobel Prize. One is physiology and medicine. Both of them, Dr. Huggins and Dr. Shelley, they got 2 Nobel Prizes for this. All right, so I think this is one of the topic that is very confusing to everyone, including primary care, everybody. So everybody hear different thing. Should we screen or we should not screen? And as an oncologist who treat prostate cancer, is very confusing to myself. So one thing is, I'm just going a little bit of basic. I know many of you know from the medical school. So there are, when the cancer grows, there are 4 different patterns. One pattern is a tumor A, right? That is so tiny, microscopic, it will never ever probably express as a clinical disease. Maybe in near future, we might have technology available. Still, we are seeing some different technology we might be able to detect, but they are probably clinically never be significant. So you really don't need to screen those people. Even if you have this cancer, you don't need to screen. We don't need to know. But we know nowadays, this, what is the 23andMe, this kind of thing, that getting genetic profile, they dig into that finding those, but is they clinically significant? No. So we know that they are not clinically significant until analysis with new information. Other group, like pancreatic cancer, lung cancer, Dr. Martin Street. So those are, you have a screening window, a year or so, right? So if a pancreatic cancer is highly likely that develop and that progress within this window. So if you do yearly screening, you may not catch the time point, which is a ideal time point, catch a disease before the diagnosis. So in many aggressive disease, screening may not be effective, but we are trying to improve those processes, how effectively you can diagnose early. But even a very aggressive disease, which is this curve showing that you get asymptomatic very short period, then you get symptomatic very short period, then you progress. Then there are two other groups in which prostate cancer lies. One is this group. This group is, you probably has a very long indolent period here. Then you get symptomatic little bit, but you probably live without getting too much of a consequence of this disease. So this is our concern is when you screen, when you get the patient before the symptom, you're probably artificially thinking they're living longer, but essentially we are not doing a good job to the patient. Maybe we are diagnosing something which they have no consequence. So this is the main concern about prostate cancer screening, is overdiagnosis. So you are getting disease without really any symptom, and then you continue follow. And when it's overdiagnosed, you overtreat. You try to treat and giving the patient the consequence of treatment factors. Then other one, this should be the ideal one, that when you get diagnosed early in the asymptomatic phase and you take some intervention and you bend this curve towards longer life. So this is the goal of screening, that is to save life and reduce morbidity related to the disease. So at this point, I think main concern of United States Task Force is that we are overdiagnostic case. So they are very conservative in terms of how to recommend the screening. But at the same time, we know that there is a group of patients, as I mentioned earlier, that 20-30% patient metastatic at diagnosis. Those patients, if you diagnose early before the symptom by screening, they may live longer. We are actually seeing that a lot. That's why the controversy arises. So talking about in a minute before, this is the, that I just mentioned why it is overdiagnosed, because 70 to 80% patients are screen diagnosed in this country. They don't have any symptom. They got PSA in the primary care's office and they got diagnosed. And that was available since 1994 by FDA. The problem with the PSA is the operating characteristics. There is no magic value you can tell, oh, it's a prostate cancer. No, there's not a single value which is diagnostic. Actually, about 15% patient has a normal PSA at diagnosis. And there is about 40% patients. So see how big the number is. If you have a 80% screen detected, about half of them probably never need treatment in their life. But we get the diagnosis, we treat them. But the main other factor is that we know that African American population has the significant high risk of prostate cancer than other ethnic groups. But they are so underrepresented in screening trial. It's less than 10%. So I think it's less than 5% in some studies. So it's very, very small population which has the highest risk. So even if you do screening, we are not screening the highest risk population who can benefit from the diagnosis. So this is a real controversy comes from the PSA-based screening. And there is a very recent meta-analysis, the systematic analysis published in JAMA. They looked back into most of the screening trial is actually 2 million patients who are screened, and they found that there are 18% patient has false positive rather. It's been screening is falsely positive, and that led to almost 50% of our diagnosis. But this is the, as an oncologist to me, and for many patients who are high risk, this is the question is, they showed that if you screen the whole population, they are not a benefit, you're not saving life, but you are diagnosing. But if you diagnose a certain population, they can have lower metastatic disease, and you can save life. And that was actually, if you look at this curve, if you look into this, so this is the time in 1990s when the PSA has been introduced. And then you see how significantly jump the incidence of prostate cancer in the United States. Then United States task force tell, oh no, I think we are diagnosing more. Let's stop doing screening, okay? They stop doing screening, and then you see how it come down. All right, so the recommendation, then there is a confusing recommendation from task force, confusion in different societies, somebody that you should do it, somebody you should not do it. But the latest data said that, so this is the around 2012, when United States task force tells us not to screen, and you see the mortality started increasing. And there are in-depth studies showing that that is increasing because patients are diagnosed more as a metastatic disease. So now, yes, oh yeah, probably we should take it into account. So now actually the latest recommendation is this one, is 2018. There's individual one based on discussion of potential benefit and harm. So this is the latest one currently. And there is the age restriction, you should do between 55 and 69. But if you go by the American Cancer Society recommendation, they have a much more liberal recommendation. They do like 50 years or older, and high risk like African American who has a family history, they do 45 years. So there's a little bit of discrepancy, but now we are not in the era of not doing screening. I think we have to, if somebody is African American, they're giving a history of prostate cancer or related cancer like pancreatic cancer, colon cancer, breast cancer, which is genetically linked, I think we should screen them definitely. Not everyone requires screening, but this is the current status that at this point, the latest recommendation, we probably need more data to tell that how we can really able to make difference, meaning that saving lives, but that is a different discussion. All right, so at this point, this is the screening thing. And before going next, is there any question from anyone I can answer? All right, good. So when I did the last grand round, these are not in the slide. These slides are not there. So we have some really, really very cool, I said cool diagnostic modalities that are helping us to refine the diagnosis and treatment protocol. One very important thing is MRI. So if you get a screen diagnosis, PSA high, the usual algorithm in the past, you go to biopsy. It's a blind 12-core biopsy, and you get up to 50% false positive like screen, and it's negative on the biopsy. It's a high level of false positivity by the screen. Then nowadays, over the last 10 years, there is a 2 randomized study done, which showed that MRI can be really, really useful. So after screen with high PSA, you do MRI, you look at the prostate, is negative, don't go for biopsy. If it's positive, go for biopsy. So MRI makes a huge difference in terms of as a gatekeeper of doing biopsy in prostate cancer. Second thing, conventional testing scan. So we get a diagnosis of cancer. We do try to see how much spread. It's called staging. And conventional scan, CT scan, bone scan are not really, really optimal. It's almost, sensitivity is almost 50% or 60%, like 30 to 40% patient we can miss the diagnosis of conventional scanning. So we have a new modality we call PET-CT, which is not FDG PET. What you do is a PSMA PET, I'll talk about in a minute. So this PET actually is changing that one. We are getting much more confident, much more sensitive way of staging patients. So this is a MRI data. There are 3 randomized study, precision MRI first and 4M, and they showed that you can actually avoid biopsy as high as 49% patient. So starting from like, this is one of the very good quality study. You can have biopsy 28% patient, and it can be as high as 49%. Another thing is when you do the biopsy, blind transrectal ultrasound guided biopsy, you're blindly really picking stuff. When you use the MRI and you do targeted biopsy, you actually get clinically meaningful code to look under the microscope. So that actually increase the clinically relevant disease. Let's see, we'll talk about in a minute that when you do pathologically classify prostate cancer, we go by the term of Gleason score. So Gleason 6 is really indolent disease. Gleason 8, 9 is very significant disease. So it is possible that you're blind 12-core biopsy because lots of Gleason 6 disease, which are not clinically relevant. But if you do targeted biopsy based on MRI, you might get clinically relevant disease which require treatment. So these two things, MRI is one and the PET scan. So I'm getting a little bit of more. So prostate-specific membrane antigen, PSMA, this is expressed by the prostate cancer almost 80 to 90%. The highly expressive protein by the prostate. So you can label it with gallium for the scanning, level with 170 lutetium for targeting treatment. So there are huge development over the last 5 years. This is FDA approved right now. But this is one of the things that makes it extremely sensitive. And this is the data, one of the earliest data which showed, look at the sensitivity of the conventional scan. If you do the CT and bone scan together and you do this. So depending on every level, if you're looking at the nodal level, it's a metastatic disease, distant metastasis, every level is extremely, extremely sensitive for these. So this is really, really making huge difference in terms of how we stage disease and how we plan to treat the patient. So this is two really, really very recent development. Other thing, the treatment. So before talking about the treatment, we have like 10 minutes. I'll talk about treatment part. So before talking the treatment, so we need to know how really the prognosis of prostate cancer. So 80% patient we already discussed, they are diagnosed in early stage and their 5-year overall survival can approach up to 100%, 90 to 99%. But if you have a metastatic disease, so is actually about 30% total, 5% at the time of diagnosis, but other 25% can come from like initially local diagnosis, then they develop with the metastatic disease. Their 5-year survival is 30 to 40%. So this is like 70% people will die. So this is as bad as other kind of cancer. So it's a metastatic prostate cancer, particularly in the advanced stage, is very bad disease. So we need to recognize that so we can actually counsel and treat properly. All right, so this is what I'm just mentioning. So the first step of diagnostic, after diagnosis prostate, the risk stratify, how risky it is. So one is the Gleason score, depending on how differentiated the glandular element, starting from well differentiated to very poorly differentiated. Score as like 3 plus 3 is lost indolent disease, or 4, 5 has the aggressive disease. So nowadays the Gleason score has been combined with staging. So and the staging and the PSA value. So we got a great group based on combining these 3 factors. And if you look at the curve, this clearly differentiate the survival. So this is the highest survival with the grade group 1, lowest with the grade group 5. So it's a combination of PSA, staging, and the Gleason score. So this is very important for treatment decision in the localized prostate cancer. Not everybody is treated very similar way. One important development I just want to tell you that happens is that when you have a low risk indolent disease based on the risk stratification, particularly Gleason score and the staging, what I mentioned, you can be very passive in treating. So study shows that is a 10-year data available showing that the outcome between surgery, active monitoring, and radiation are same. After 10 years, only 17 people of 1,600 people died in 10 years from the prostate cancer. So it's extremely low disease severity. And then after that, so one thing they noticed, what we also discussed a little bit in terms of screening, that the people who are on active monitoring, they tend to develop more aggressive disease than the people who are not on active monitoring. Obviously, if you do surgically take it out, it's not coming back in the prostate anymore. But the active monitoring, but that can be treated at that point. So, but bottom line is that active monitoring is an important part of a huge number of patients who have a low risk with a Gleason score 6 or stage 1 disease, which are clinically asymptomatic. So this is the one thing I just want to convey. Active monitoring is a viable strategy. But other people who are not low risk, intermediate, or high risk disease, so really the two definitive treatment, one is the radiation and surgery. So these are the standard of care treatment. So I'm not going in detail. I'm not a radiation doctor or surgeon, so I'll let them discuss at some point. But really the treatment of localized in the prostate is active monitoring, then radiation, and the surgery based on the risk profile. The problem is, even you treat relatively intermediate high risk disease patient, 30% patient disease will come back. So these are the people, they are actually going to aggressive disease process and the treatment monitoring for their whole life. So 70% people probably will get cured, but 30% and develop from their like possible cured state to an incurable state. So that's why this is just a little bit of more. So diagnosed like 90% of the localized, 80 to 90%, then you radiation, prostate, almost 70% get cured, and 30% eventually develop metastatic disease. And then 6% develop de novo metastatic disease, meaning that metastatic at presentation. It's a national data. I see here in VCU, we have a much more metastatic disease at presentation. I don't have a very solid data, but I think we have much more disease than metastatic presentation, and they eventually die, no matter what you do. All right, so this is the like a metastatic spread. It goes predominantly in the lymph node, bone. These are the two most common sites. So for the systemic therapy, when you are passing the stage of localized stage, we're talking metastatic disease. So over the last 100 years, almost, we have a lots of development happen. I'm not going detail. We talk about in 1960s with Dr. Huggins and Haas, they got the Nobel Prize. This is still the one of the mainstream treatment, but a lot of development happened after that. We'll talk a little bit. I'm not going to the slide in detail. So this is the one, the blockage of the androgen is the backbone of any treatment, any systemic treatment. So blockage meaning that it's monitored from the hypothalamic pituitary axis. So if you could block the gonadotrophin releasing hormone by antagonizing it or agonist or antagonist, you can block it or you can accelerate it for a feedback inhibition. Then you stop making testosterone from the testis and the adrenal androgen. So this is the basic principle you can achieve by orchiectomy. You can take that testicle out. Is a local treatment rather than centrally acting, but you can block using agonist or antagonist. This is a new drug, just happened like last few years ago. Used to be all these drugs are either intramuscular subcutaneous with oral drugs is available for patients now. And other new drugs which is available is actually first approved in the 2011, and they are the mainstream now. So we can actually inhibit the synthesis of androgen by inhibiting enzyme called CYP17. So this is a prototype abiraterone, and then you can block at the receptor level. So androgen receptor would work at the tumor level, you can block. There are a number of drugs that are available. So these are the like kind of a mainstream treatment over the last, I would say 2011, like 10, 11 years. And now we learn over the last 10 years is that, so mainstream treatment you treat using only androgen deprivation drugs. That was the main background of treatment. But over the course of last 10 years, if you look at the data, we're adding one after another. So we are adding like conventional traditional androgen deprivation drug with a new drug like abiraterone and enzalutamide. or androgen deprivation drug is docetaxel. Very recently, we actually used a triplet, all three together. So we are adding more and more, but thankfully, all of them had showed significant survival benefit. So we participated in this trial, Erasmus in VCU, and it has overall survival is around, it's reduced mortality by about 30% compared to like doublet. So more is better. That is the concept. And one of the concern definitely is the toxicity, but we have not seen any significant toxicity when you use triplet or doublet. It's like very comparable. So this is currently the mainstream treatment. If you have a advanced metastatic disease, depending on the volume of the disease, depending on the spread, you try to be more aggressive upfront. So this is what is the like last 5 years, we call the concept of ADT, androgen deprivation intensification, early in the disease process. So rather than treating a little bit, we had a tendency in the past, we treat a little bit slow walking. Okay, so let's not treat very aggressively, you are old, but that concept is being changed nowadays, getting more aggressive upfront. But the problem is, so this is the hormone sensitive disease. You are still responsive to hormone. Then the body develop resistant, and there the problem starts. Once you develop resistant, people will die in 3 to 4 years. So there is not really beyond the androgen deprivation, other treatment, we are evolving and emerging treatment modalities. The benefits are still yet to see whether it's making huge difference. Okay, so there are many drugs. This is the mechanism how the prostate cancer develop resistant. So one is the receptor overexpression. There are more receptor expression in the tumor. Then receptor can be mutated so that no longer the androgen can work on it. There are some other mutation variant and the splice variant. There are some bypass pathway, how prostate cancer is no longer dependent on androgen dependent pathway. So they're no longer dependent on testosterone. So blocking testosterone does not help anymore. So they become castrate resistant. And so in the past, like these are available in 2011, we used to use androgen deprivation therapy using some of the new generation potent anti-androgen drug. This is still the mainstream. There are many studies showing there is a survival benefit. So this hazard ratio for overall survival, but they're effective drug. But what really is the current focus of development is, can we do non-hormonal treatment? Because hormonal treatment is still important, but it's no longer really making a huge difference anymore. So one is the like traditional chemotherapy. So that's what. Second is some targeted therapy. So prostate cancer is a bone dominant disease. It goes to bone a lot. And this is the radium-220, the radiation particle, which directly just go to the bone and kill the cancer cell. There's a new one, you just mentioned, PSMA targeted. So you can level the PSMA molecule with the antibody and the radiation, 117 lutetium, and then you can treat. This is actually very cool concept, is that some people like BRCA mutated, or there are some other we call DNA repair gene pathway defect. There's you have cell die and our body tend to repair them, but the mechanism is defective. But there's the enzyme which is very important to get this repair ongoing, which is called PARP. So there's a drug called PARP inhibitors, which can actually block complete repair, almost impossible. So they are now available for prostate. That same mechanism is possible for BRCA positive, like breast cancer, BRCA positive ovarian cancer. So this is a really significant improvement over what we have. One thing is very disappointing in prostate cancer world is the immunotherapy. Okay, so immunotherapy, you know, everybody knows, irrespective of the oncology practice or not, that it's making huge difference. Okay, it's making incurable disease to curable. It's prolonging life. It's prostate cancer is very disappointing. Our clinical trial data shows is only 10% success rate. It's primarily because prostate cancer is not too much immunogenic. Number one. Number two, there is an antigen, a new antigen expressed by the tumor cell. Prostate cancer is not known to express too much of a new antigen. So there are many other mechanisms, I'm not going detail, but in general, immunotherapy is not very effective. what we see in other cancer. And then these are some of the data. I'm not getting too detailed. So this is the radium-223 compared to placebo. It shows that there is a survival benefit, is PSMA targeted. So there is a, if you see about 25% improvement in prolonging life, reduce risk of death. This is the BRCA1, BRCA2. This is the prototype drug we call olaparib. And olaparib has, if you look at the data, it's like 30 to 70% reduction in the death in the particular setting. So they are very exciting. There are lots of drug coming in, which I'm not going. I spent the last few minutes on the quality of life considerations. So one thing, majority of the people who survive the disease and the localized disease, they are old, 65 years old. And then they get treatment. They got either prostatectomy, they get radiation, they get hormonal treatment. They have a profound lead side effect from the treatment. So nowadays, almost every study, FDA mandated them to do a quality of life follow-up, how they are doing on the treatment, so that we know that how they are really, not only in prostate cancer, many other cancers, we really focus on the quality of life issue. With prostate cancer is particularly important because late side effects are so common. So this is one, there's some common side effect, and almost everybody gets some degree of sexual dysfunction. It can be erectile dysfunction, it can be decreased libido. And so depending on what kind of treatment, and active hormonal treatment, almost 100% people get sexual dysfunction. There's a significant cardiovascular morbidity, including major cardiovascular event. Risk is significantly higher. There is a concern that is a cognitive impairment from hormonal therapy and other kind of potent hormonal treatment that has not been really confirmed, but because the elderly population, you cannot really assess cognitive function very well, but this is a concern. People get metabolic syndrome after get cured and getting hormonal in their life, and definitely bone loss because hormone therapy is associated 5% per year. So this is the important part of survivorship. More importantly, really not the physical thing, they're important, but psychosocial effect. And if you ask, is it maybe male thing? It's also female thing, or the breast cancer survivor. The male thing, they are so much depressed and anxious because they are maybe, I think, caregiver for the whole family. And even though they are cured, they are very, very extremely stressed about recurrence when it will come back. So this is one of the psychosomal. Many patients develop depression and definitely sexual dysfunction. They get obese after hormonal treatment, the self-image issue, and financial stress. This is definitely treatment during treatment, a very expensive treatment, and these are the things that really affect them. And there is a really comprehensive effort to develop survivorship care. I talked about clinical trial data. I think it's important we advise the patient what to expect, even though they're cured. And important step is the cancer survivorship clinic. We have a clinic here in VC. I think they're doing an excellent job. And there is actually a comprehensive guideline which is developed in 2014, American Cancer Society guideline, how we, and importantly, you also look for the patient develop secondary cancer in their survivorship life. And this is some framework, what I just mentioned is proposed by National Institute of Health for the survivorship care, how you do. So that include a lot of things. You can look for the new cancer, physical effect, psychosomal effect, your comorbidity and chronic condition, and the promotion of health, like diet, exercise, and this kind of thing. So this is a very comprehensive effort ongoing, and many centers develop survivorship kit based on this framework. All right, so I think this is my last slide. So I'd like to thank my patient, my colleagues in the clinic, and definitely all the staffs who work with us in the clinic. And I'm ready for any question if you have.
So one thing that has to do with survivorship is germline testing, right? Because it has, somatic testing has become a mandate, as there are some therapies that are directed to those alterations, but of course, if they're positive in the tumor, then are they positive as germline? And that has family implications as well. So how are these discussions being carried on?
So over the last, so we do almost everyone with a metastatic disease, germline testing. So that germline and somatic, so that we know whether they have a family connection, and we advise send to genetic counsel. This is part of the standard treatment almost every place. And I think our genetic counsel very busy, it's just dealing with a prostate cancer patient. So this is kind of getting standard. We don't know the implication who are cured, and you do testing for those people, and how it actually is a general question rather than prostate cancer specific. If you don't have an active disease, just because you have a cancer, should you do germline testing and find out which may or may not be relevant? But the way technology going, the way we are, science is advancing, I think at some point everybody will get some kind of sequencing and germline testing. Prostate cancer at this point, high risk disease and metastatic disease are strongly recommended to germline testing, and we get it, send patient to genetic counselor. I think it is getting standard of care at this point. For the survivorship framework, the framework is a little bit old, but there is a mention about comprehensive care and the risk stratification and recurrence. I think they will update this based on what we know.
Any other questions from the audience here?
Anyone has any other question?
Yeah, about the MRI trials, did they use like specific cutoff to select patient for prostate MRI versus send them to biopsy right away?
What is the question?
So like for the patient, we used MRI to basically avoid prostate biopsy, right? Did they use like a cutoff?
So there are no cutoff. So cutoff is very arbitrary because there are no evidence-based cutoff. But there are 5 or 6 randomized trial, and every trial has its own cutoff, how they decide patient. Some people may have screen positive, they did MRI, and they have a MRI like by rate criteria positive, and then they do the biopsy of those patients. But every trial is different. The inclusion criteria is different. But in general, PSA is not only the criteria for the randomized trial entry. Anything else? Yeah.
So I have one quick question about the CIPRU cell that was on one of your slides. Last time I checked the NCCN guidelines, it's still on the approved as a therapy, but I just haven't seen it.
Yeah, so interesting, I didn't mention, I have to mention in one slide. So this is the first immunotherapy which is really approved by FDA for metastatic disease. So it's approved only for asymptomatic, low volume metastatic disease. The high price is $90,000, 3 doses. The problem is the study showed that it has only survival benefit. It does not have like PSA as a marker. It doesn't have the radiological markers. You don't assess whether they work or not. So this is it's an autologous cell. You collect the cell and treat it GM-CSF and then send back and get the immunogenic reaction. But that is kind of getting less and less clinically applicable right now because we cannot monitor. But there are new trial coming in with Cell plus new drugs like Pluvicto. Okay, so there is a trial actually. Yesterday we were talking in the LNG Oncology group. There's a concept coming in just using this one with another standard of care drug. So that might make a difference. But at this point, I don't practice myself. I think $90,000 is not worthy to get no really meaningful monitoring parameter when monitoring out. All right, so we are right at the time. If anyone has any question, anybody in the audience? All right, thank you so much.
Thank you so much.
Okay.